The next will be Dr. VANATHI. Dr. VANATHI is a professor in All India Institute of Medical Sciences in the Department of Cornea and Refractive Surgery. She'll be talking about topical steroids and NSAIDs.
Thank you, Dr. Srini. It's nice to be part of this really interesting course, and I should congratulate Srini for crafting it out so well, something which commonly toys on our minds. All of us are prolific cataract surgeons here. So I'm going to speak to you on topical steroids and NSAIDs, the choice, frequency, and duration, no financial interest. The basic know-hows, I think Srini has already covered here. So what you would probably want to know is that ocular steroids exert their anti-inflammatory effect by inhibiting the phospholipase A2 and thereby inhibiting both the cyclooxygenase and the lipooxygenase pathways, and have a propensity for elevating intraocular pressures, especially in eyes which are predisposed or eyes which are steroid responders here. So I wouldn't go on more into the molecular basis of these medications, but one interesting publication which has recently come out is which talks about the penetration of topical and subconjunctival corticosteroid therapy into the human aqueous humor, and what is the therapeutic significance when you look at this. So when a variety of available topical ocular corticosteroids were used on the highest aqueous concentration within 2 hours was looked at, and was seen which one maintains this concentration. And as you could see in this graphical representation, what we can see is the prednisolone acetate is the one which achieves the highest concentration in the aqueous on installation, and a very rapid achievement of the aqueous installation. So that itself is something which tells us the pred acetate is probably going to be the one which we would all want to use in terms of being able to achieve good control of intraoperative or inflammation control in the anterior chamber. So now let us look at what are the various medications we have in our armamentarium to put to use to control the ocular inflammation, the surface inflammation, and the anterior chamber inflammation. I think we all know about all the medications: loteprednate, difluprednate, fluoromethalone, prednisolone acetate, and phosphate combinations, and dexamethasone and betamethasones. So largely what we do use in our practice now is prednisolone acetate and versus phosphate, and difluprednate is the newcomer, and we are always debating on whether we want to place the difluprednate against the use of prednisolone acetate. Loteprednate and fluoromethalone are largely what are known as low potency steroids or ocular surface steroids, largely because their intraocular penetration is not so good, and they are effective in achieving therapeutic efficacy on the surface of the ocular of the eye here. And betamethasone is largely one which is used in dermatological practice. We do not use much of it in ocular practice, and we do want a very potent ocular surface effect. We would resort to dexamethasone. So that said, that's the basis on how we would go about choosing your medications here. So what, as I already mentioned, is would you like to use difluprednate against what we conventionally use for cataract surgery, which is prednisolone acetate here. So prednisolone acetate here, being an acetate here, the penetration is much better as compared to the prednisolone phosphate here. So that itself scores it when you're preferring to control an eye with a greater amount of intraocular inflammation. And as Srini rightly pointed out, today's cataract surgery is largely inflammation free. I think the scenarios where you would probably be looking at anterior chamber flare and cells beyond 2+ in uneventful or uncomplicated scenarios is much less here. So a prednisolone acetate works well. Again, this is a nice table here which looks at what is the anti-inflammatory potency in vivo and in vitro of the various ocular topical steroids which are available. And this clearly sees, look at the right column here, the right extreme, which talks about the in vitro potency of these medication, and you would see that difluprednate scores much highly over most of what we have here. But that's in vitro, so when you're looking at it in vivo, they are almost comparable, but still the leader being the difluprednate, and what close closely follows is going to be our prednisolone acetate in terms because it achieves a much better concentration. I think these are many of these are RCTs and systematic reviews and meta-analysis are freely available on the internet, and I would urge you all to go back and look at it if you want to have a greater understanding. But in the interest of time, we probably will not go into it. But according to the recommended current guidelines, which are recent, in patients undergoing cataract surgery, when you're looking at topical anti-inflammatory used, the main aim is to control the inflammatory response, and two is to treat established cystoid macular edema. So these are the two concerns for which we would probably want to think about using topical steroids or topical NSAIDs in our patients here. So what are the tenets, or what is going to be guiding us, or what's going to be the protocol in the use of ocular topical steroid therapy? So this is a nice step ladder which I've just laid out for you to understand. And when you're inducing or with the induction of topical steroid therapy, use the strongest always to control the inflammation. Again, many of us tend to taper fast. Remember, there would be a rebound effect here. So taper only once your inflammation is controlled optimally, maximally here. And once you've controlled, then you can go in for a faster taper. Maintenance therapy, probably use the minimum effective strength and dose that would work well. Adopt a custom approach depending upon the type of ocular surface or the type of cataract which you are, the type of eye you are dealing with, and that is going to have you probably will add on a custom component to this. Monitor the high-risk eyes for adverse effects here. So that's something a cataract surgeon needs to be keeping in mind. See, 9 out of 10 surgeries, you probably need not to apply these protocols, but there is that one surgery which probably can land you up and give you a headache. So that's when you probably will have to know about what are these problems here. Preoperative prophylaxis of steroid therapy or NSAIDs, again in predisposed eyes here. And the synergy with topical steroids, whether you want to use NSAIDs alone or whether you want to use NSAIDs in combination for steroids for control or for management of cystoid macular edema in predisposed eyes, is something which is on the annual and which is being highly debated this year. So now with these said, I'm going to move on to talk about the various NSAIDs which we have with us. So what are the NSAID complications? It is SPKs. You have punctate keratopathies here. You can get epithelial defects and you can get corneal thinning. But this said, again, you don't see it in all ocular surfaces. You only see it in ocular surfaces which are going to be compromised, and when you're going to adopt cataract surgery in such compromised ocular surfaces, you're probably going to pay a lot of attention to this particular. So in the high-risk groups, meaning diabetic ocular surfaces, previous herpetic diseases with corneal scarring, in the presence of severe dry eye disease here, patients with prior Bell's palsy, rheumatological disease are the high-risk patients in which you're going to, there's going to be a warning bell, then you're going to use NSAIDs on these surfaces. Preferably avoid NSAIDs when you're looking at or doing cataract surgery in patients with sarcoidosis, rosacea, chemical burns, irradiation, history of irradiation, ocular GVHDs, neurotropic ocular surfaces, large epithelial defects, keratitis, ulceration. So almost the group overlaps each other. So just for making it easy, you could put the pool in the group together and be aware when you're going to use NSAIDs on this kind of a scenario. Again, prescribe judicially where you probably need to use your NSAIDs in terms of wanting to prevent postoperative CME here or to treat postoperative CMA. The recommendation is you would use it for 2 weeks here and do taper it as far as this, as soon as the cystoid macular edema heals here over here. And if you need to use them over a period of 2 weeks, please schedule a follow-up as frequent as 6 weeks, especially in eyes which are compromised here. So that is the international recommendation here. Again, remember, NSAID uses for postoperative CME is an off-label usage here. So you would want to use them in those cases where, or those eyes which are predisposed to the occurrence of CME. That is when there is an increased iris and intraocular lens touch here, chaffing, which causes chaffing where the iris is adherent to the wound when you have vitreous in the wound and there's a continuous vitreous pulse. These are the eyes which are going to be predisposed or which are going to have a higher incidence of cystoid macular edema here. And a minimal non-therapeutic dosage is probably something which you'd want to use for a long period of time in terms of the ocular surface effects which these medications might have. But beware of the risk of corneal complications here. And again, to emphasize, what is recommended as a protocol internationally is a 6 weeks therapy, beyond which frequent follow-ups here. Again, be aware of poor healing responses when you're using NSAIDs. That said, again, it's not going to happen in all the eyes, but you're looking at with compromised eyes, you probably will be wary of wanting to use, be careful of wanting to use these NSAIDs or steroids for a longer period of time. In the interest of time, I'm not going to go into all these studies. I've sort of summarized these into what is available when it was a good learning experience for me as well to review the literature on this. And this is what I found about 10 to 14 studies is what I looked at. And largely what what plays on our mind is, I already talked to you about the steroids, but when I talk to you about NSAIDs, what we are largely looking at is Nepofenac versus Bromfenac. That's what is going to be playing on your minds. And I do not allow the company people to bombard our minds or to guide us on what we need to use. Please always think for yourself and think what works best for your patient here. But by and large, the Cochrane study, which came in 2017, places us or makes us understand that whatever we have till now, the evidence is probably insufficient to prove an equivalence or superiority of using either NSAIDs alone or in combination over steroid usage. But when this is for ocular inflammation, but when you're looking at the control of the risk of CME, is definitely lower when you're using NSAIDs, or you can prefer to use them in combination with steroids. So I still feel using NSAIDs in combination with steroids is probably the recommendation, though evidence is not pointing much on its things. That said, these are the earlier studies from 97 to 2017. Beyond 2017 to 2022 is when we had the advent of Nepofenac. We have varying concentrations. I think different companies bring different combinations to you here. Bromfenac also comes as a different combination. But the current evidence based on these studies, again, these are not largely comparable because each of them have a different methodology. Each of them have used a different topical application pattern and a different percentages here. But Nepofenac 0.3% is largely what is scoring, and Bromfenac seems to probably have an equal efficacy. Bromfenac 0.09%. So these are the two players which we are seeing in what's available to us of late. But please always be aware of the complications in eyes that are predisposed to affection because of poor ocular surface. I think I'll stop here and thank you.